afternoon, lady. Professor Powis, on the subject of DNA CPRs, I think there were 2 further communications with the system. On the 11th of May 2020, a primary care bulletin reiterated the importance of appropriate DNA CPRs and not imposing them in or drafting them in inappropriate circumstances. And then again on the 4th of March 2021, were there any particular triggers for these repeated notices to the system?
I can't recall that there were. I'm very happy to provide you with information if there was. As I said earlier, I think this was predominantly brought to our attention at the very start of Wave 1 at the end of March and early April 2020.
In terms of some steps that were taken by NHS England in relation to this issue, I think you explain in your witness statement that on the 4th of September 2020, the guidance, the quality outcomes framework for GPs was amended. They were asked to restore proactive annual health checks for people with learning disabilities and autism, and to review all DNA CPR decisions and confirm that they were determined appropriately and continue to be clinically indicated. Can I ask you this? Was it intended that general practitioners, in conducting that sort of review of their patients' notes, should report any inappropriate DNA CPRs to NHS England? And were NHS England notified of the outcomes of any such reviews?
Not that I'm aware, and I think it was, so QOF is an incentive scheme for general practitioners where they have additional incentives, financial incentives to target particular areas of work. In fact, that work would have been disrupted, and I'm not confident it was fully implemented because in the following period, once again, we had to suspend QOF to redeploy general practitioners. So the QOF system was not operating as it normally would outside of pandemic times because of the requirements at times to release general practitioners to assist in other activities such as the vaccination programme.
Can I ask you this? Normally, if it was part of the QOF framework to review patients' notes in terms of monitoring diabetic patients or medication or anything else, would it normally be the case that that sort of patient record review would result in a notification to NHS England? Was it usually reported on, or was it more of an internal process?
It depends a little bit on the QOF indicator. So we would have information on which practices had undertaken the particular QOF indicator or the response to it. And if that QOF indicator required the generation of data, then there may be ways that we could collect that data. So, for instance, a QOF indicator incentivizing monitoring blood pressure, identifying new cases of high blood pressure, we would be able to get the data in terms of how many patients had their blood pressure identified or treated to optimum standards.
But so far as you're aware in relation to this DNA CPR review,
no, and
it doesn't appear that data was...
No, and because of the operational disruption as to whether it actually got as far as being a QOF that was used in practice. But very happy to provide further information.
Thank you. A related matter, you explain in your witness statement that I think in response to the recommendations of the Care Quality Commission report, which you referred to earlier, which was published in March of 2021, I think that's right, NHS England developed an advanced care planning document, is that correct? Would it be right to say that the document that was developed there, I think it was called the Universal Principles for Advanced Care Planning, was a broad statement of principles to be applied rather than a document to record those conversations between patients and clinicians? Would that be correct?
Correct.
So it's not analogous to the RESPECT form, which the inquiry have heard something about.
The RESPECT form would be one form of implementation of those 6 principles.
And did you consider that the respect form, in its current form, could comply with those universal principles for
Yes,
advanced care?
I'm sure it would. As part of the production of that document, my understanding is there were discussions subsequent to that document as to whether we should have a single form or a single process. And the view of NHS England colleagues at the time was that the overriding priority was to have the 6 principles embedded rather than mandating that a particular tool, a particular form or a particular process should be used. As you know, the respect form is used in many parts of the country, but there are other processes in place in order to apply those principles. And our view, as I've discussed with you earlier, is that we do like to allow local flexibility so that local healthcare systems can determine what is best for their populations and patients.
The Resuscitation Council UK, who developed that respect form, made a recommendation to the inquiry that it would be better, for reasons of consistency and for other reasons, for other practical reasons, if there was a universal form of documentation to record patients' wishes, advanced care plans, including DNA CPR wishes, that should be applied across all 4 nations of the UK, whether that be the respect form or a different form. What are your views on that recommendation, on the utility and benefits of having a uniform single document across the UK?
So I can certainly see the value of that approach, and I read the evidence from the Resuscitation Council. As I said, when it was discussed at NHS England, our view was that it was the principles that were important and not necessarily having a standardised form. That is currently the position, but I absolutely see that there is some merit in standardisation.
So on a related note, if we can move on, please, to palliative care and end-of-life care
Yes.
in hospital for COVID-19 patients. In your third witness statement, you said, as the pandemic developed, NHS England was not aware of a system issue with capacity for end-of-life hospital care, and provision was available to those who wanted and needed it. You have been provided with the witness statement of the president of the Association of Palliative Medicine, that's Dr. Sarah Cox. I don't think we need to get that witness statement up, but it's INQ 000257329. And Dr. Cox has noted in her witness statement 5 main issues that she had identified in relation to palliative care during the pandemic. And perhaps I can summarise them in this way before I invite you to comment on those. First of all, she says that there were not enough palliative care specialists to see everyone who was affected, and concludes that that will have resulted in gaps in care for some. That there was unclear, conflicting and constantly changing guidance on visiting restrictions, which made the situation difficult for families and loved ones. That the relatives of patients from ethnic minority communities were disproportionately impacted by those restrictive visiting practices because they were unable to fulfil religious and culturally prescribed responsibilities around the end of life and death. And there were communication challenges for families who did not have English as their first language because of the limited availability of telephone interpreters and the restrictions on visiting. And she says that all of those factors together resulted in a degree of psychological trauma for staff involved in palliative care. And I'd like to ask whether you accept those points that were made by Dr. Cox and whether NHS England was made aware of those problems in palliative care at the time.
Yes, so I with a caveat that I will come to in a minute, I think we would accept that the palliative care service and palliative care teams were under significant pressure, as were many other members of staff, particularly during the peaks of the pandemic. They were having to treat many more or care for many more patients. The settings in which they had to do that were more difficult, and indeed this was undoubtedly one of the most traumatic parts for staff and, of course, for patients and relatives of all of the pandemic. And I don't underestimate how difficult it was, and I'd like to obviously pay tribute to our our palliative care teams, both specialists and generalists, because I think they did a fantastic job under really difficult circumstances, having to support staff in adapting to the way in which end-of-life care could be managed. But you know, it is correct that they were stretched, as you have seen in Dr. Cox's statement. The one issue that I might caveat a bit, and we may come to this, is on visitor guidance, which goes back to the discussion that we've had on the pros and cons of issuing guidance. We did issue visitor guidance. In fact, we had not got national visitor guidance prior to the pandemic. And that went through, I think, 3 iterations in wave 1 at least. The principle was to try and make it more flexible as we progressed, as we learnt more about the virus. And certainly later on in the pandemic, as testing became more available, as PPE more available, as treatments more available, then the direction of travel was clearly to try and relax those. The guidance, clearly visitor guidance is a balance between the risks of nosocomial infection and spread and allowing people to visit. And of course, as I've said earlier, principle is to try and give flexibility to local organisations. I think you heard from Professor Ball some of the flexibilities that they applied in Birmingham, because no estate is the same, staff are the same in terms of the number of staff and the configuration and skills of staff. So you do have to allow that flexibility for local leaders to apply the guidance as best possible in their circumstances.
Coming back specifically to end of life and palliative care, and we're going to we'll come on next, if we may, to visiting restrictions, which obviously were not only in place in relation to palliative care.
No.
Patients. But in terms of some of the issues that are brought out by Dr. Cox, aside from just those visiting restrictions, do you think that there's an extent to which it is inevitable in a pandemic that there is going to be an impact and a greater demand on the palliative care service? And do you think that NHS England could have done more, or would in a future pandemic do things differently in relation to making provision for those inevitable changes and impacts upon the palliative care service?
Well, this comes to the resilience point that we may talk about later. So clearly, the more staff we have, the better. We are understaffed within the NHS in many of the professional and specialty areas compared to our OECD comparators. That is why the long-term workforce plan that was published 18 months ago by the previous government is so important for us, because it will allow us to build up resilience in all disciplines and all professions. So there's no doubt we would want to be more resilient in palliative care as we would in other areas. Intensive care would be a good example as we go forward. But even with that resilience in a pandemic where you have to, by necessity, as you've indicated, surge and stretch beyond your normal capacity, I don't think we can ever fully mitigate the challenges that people are faced with. And of course, that will depend upon a virus that predominantly affected children, for instance, would bring with it a whole different set of challenges. So I think we will prepare as well as we can. We should be more resilient, but we also have to be able to adapt and flex to the exact nature of the issue that we're dealing with.
Thank you. Can we move on then, please, to the role of NHS England in visiting restrictions for hospital visiting? And I think you referred briefly, perhaps, to the role that NHS England played. I think it's right that initially, between the 25th of March 2020 and the 6th of June of that year, there was a national visiting policy, national visiting restrictions that were published by NHS England. And I think if we can go to your third witness statement, page 179 at paragraph 685, you summarise in the final sentence what was permitted under that national policy. The rules explain that visiting will be limited to one visitor per patient, apart from in the case of a child where both parents could visit, when a patient was receiving end-of-life care, when a partner and birthing partner were accompanying a woman in labour, or if the visitor required another person to assist them. And if we could go on, please, to paragraph 686, we then explain that the visiting, the only circumstances where visiting was permitted from the 25th of March was for one immediate family member to visit when a patient was either a child or receiving end-of-life care or a woman in labour. And the rules advised on making greater use of phone and video calls to stay in touch with loved ones. There was then a revision to the guidance on the 9th of April to include an additional circumstance where visiting would be permitted to support someone with a mental health issue such as dementia, a learning disability or autism, where not being present would cause the patient to be distressed. We can take that down now, thank you. Do you think it was an error in the initial guidance when it was published on the 25th of March not to have permitted expressly visiting for people with dementia, learning disabilities or autism, not to have included that exception in the initial guidance?
Well, I can make a few points on this. Firstly, as I think I've said already, this was new territory for us. We had not got national visitor guidance in place before, so it was not something that we had national experience at. Visitor guidance has always been local. And so there was inevitably a learning curve for us in terms of providing guidance. So on reflection, I think it is possible that we should have made that clearer earlier. I give you another example, which we clarified in later iterations of the guidance, I think in May, was whether chaplains, faith leaders, whether carers should be included as members of the healthcare family or as visitors. And our view was that they should be included as, in essence, as part of the healthcare family and not counted as a visitor. We clarified that later, but that was, I think, part of our learning process in producing guidance in an area that we had not previously had experience. But as I've said, the principles were that we wanted to, and I acknowledge this was one of the toughest areas of the pandemic, and it was another area of difficult choices, and the pain that it gave to staff and public, we fully recognise at NHS England. Getting that balance right was really difficult, but we wanted to be as flexible as we could and increasingly flexible as we learnt more, as we were able to put in more measures to protect staff, to protect patients and visitors. And there were areas such as end-of-life care and birthing and pregnant labour in particular, where we, from the outset, were clear that we wanted to make exceptionality. But I think you have raised a good point, and I think as part of our reflective process, then that is something that we would think about.
I think it's right that on the 5th of June 2020, NHS England then published revised guidance on visiting, which set out the guiding principles, but granted discretion to local NHS trusts to formulate their own policies. And can we have a look briefly, please, at that guidance? Thank you. This is visiting healthcare patient in settings during the COVID-19 pandemic. It explains that this replaces the previous visitor guidance that was the national policy. The national suspension on visiting imposed under that guidance is now lifted. Visiting shall instead be subject to local discretion by trusts and other NHS bodies. This guidance provides advice on how NHS organisations may choose to facilitate visiting across healthcare inpatient settings. And if we can go further down, please. There are some practical considerations that are set out there. And principally, the number of visitors at the bedside is limited to one close family contact or somebody important to the patient. Where it's possible to maintain social distancing throughout the visit, a second additional visitor could be permitted in circumstances including partners of women in labour and a family member for individuals receiving end-of-life care. We can take that down. Thank you. Some of the inquiry's core participants have reported that there was significant variability of approach to visiting in 2020 following the granting of that discretion to trusts, and in particular that some families who were carers for their loved ones were not able to visit because it was interpreted so strictly that even where they were carers, the local discretion was that they should not be able to visit. Was that something that NHS England was aware of at the time, this level of local variability, sometimes really in contradiction of the guiding principles?
So we were certainly aware of the variation, and as I've said, giving local systems discretion is important because their local circumstances change, not least if the prevalence of the virus is particularly high in one community but not in another. It would be reasonable to have a different approach to visitor guidance. And of course, that guidance was issued as we were coming out of the first wave and the prevalence in the community was lower. As we went into a second wave, again, local leaders had to begin to make decisions as to how in their particular context they would have to apply that flexibility. And I fully acknowledge that would lead to variation, and from public and patients' perspective, that would look odd, bizarre, that in one setting this was allowed, in another setting that something else was allowed. But it did reflect the requirement to enable those local leaders to look at their estate, to look at their particular circumstances, to look at their staff mix, and say, actually, at this particular point, we think this needs to be in place. Whereas at another point something else needs to be in place. It's a balance, isn't it, between the one-size-fits-all approach, which has its disadvantages, as I said earlier, and the allowing that flexibility, which brings with it a criticism that you get the variability. That balance changes according to where you are in the pandemic. It changes according to where you are in the country. So I think it's right that we give that flexibility. I would expect local leaders to use it and use it wisely. And of course, we would expect them to do it within the principles.
Can we have a look, please, particularly at the restrictions on visitors and supporters for women who were accessing maternity services during the pandemic? I think it's right that the initial guidance that was in place classed a birthing partner or the partner of a woman in labour as a visitor rather than an essential support partner or partner in care. I think it was on the 14th of December 2020 that the guidance published by NHS England on visiting and maternity services defined co-parents, if I can put it in that way, as partners in care rather than visitors, and drew a distinction between visitors to whom restrictions may apply and support partners in maternity services. And I'd like to ask again, do you consider that it was an error in the initial guidance not to define birthing partners and co-parents?
So our reflection, I think, would be that we could have been clearer, and I think this is a lesson for next time. There is a next time in making those distinctions as to who is part of the healthcare support team, if you wish, faith leaders, carers, birthing partners, and who is a visitor. And I think you saw that in the guidance as we iterated it. But I absolutely agree, one of the reflections that we would have coming out is to do that sooner and be clearer.
That was looking at, we've already heard about the partner of a woman in labour. In terms of how visiting restrictions in maternity services might apply to people accompanying a woman to an antenatal appointment or a scan, you have referred again in your third witness statement to efforts to produce guidance together with the Royal College of Obstetricians and Gynecologists and also the Royal College of Midwives. And there was a framework to support visiting and maternity services jointly published, I think, on the 8th of September 2020 by those two organisations, NHS England and also the Society and College of Radiographers, I think that's right. And that guidance enabled partners to also attend antenatal and postnatal appointments. And I think that guidance was developed by those stakeholder organisations who then asked NHS England to badge it effectively and to disseminate that framework. And you've been provided with emails, I don't think we need to get to them now, between NHS England and Jo Tanner from the Royal College of Midwives, a month before that framework was published in August, where there's some concern and frustration being voiced by the Royal College of Midwives that the guidance has been drafted and it's been sitting for some time with NHS England. What was the reason for the delay in NHS England signing off that guidance?
Because we have an approvals process to go through. And as we discussed earlier, you can rush out guidance too quickly and it doesn't go through the appropriate scrutiny. We discussed that in terms of the NICE guidance and clinical frailty. So it is right that there is a process of approvals and scrutiny, and at that stage in the pandemic, to an extent where we were not at a peak, that approvals process didn't need to go quite as quick as it did at the start. So that is an important set of balances, but I would agree that on that particular occasion, I think we could have been quicker.
Thank you. So looking at the balance that you've referred to in terms of visitor restrictions and the competing concerns that have to be weighed, so far as you are aware, was there any clear data, or is there now any clear data on the extent to which visitors were contributing to nosocomial transmission rates in hospitals?
So there's a fair amount of information on nosocomial transmission rates, and as you would work out, I guess, from first principles, that there is patient-to-patient transmission, and I think the evidence is that that was probably the predominant route of transmission. There is staff-to-staff transmission, staff-to-patient, patient-to-staff, and of course, hospitals, by their very nature, are areas where there will be a higher volume of virus because they are treating or people with COVID, or people with COVID are coming to hospitals. So I can't recollect if we have specific data on visitor-to-visitor or visitor-to-staff data. But clearly the risk of transmission occurring between any group in a hospital environment is going to be higher than it would be in a setting, particularly when there are lockdown measures in place.
Can I ask you this? Do you think more emphasis on other infection prevention and control measures for visitors, such as testing visitors, social distancing, mandating face coverings for visitors, could have substantially mitigated that risk rather than taking a very restrictive approach to visiting per se?
Yes, and they did. But of course, in March, some of those things were not in place. So we had no testing capacity to do that in March. And when testing capacity came on stream, and obviously visitors would be able to self-test at home and know whether they had COVID or not, then clearly that is a benefit. And I think the move away from a national mandated set of guidance to more local flexibility, as I think I stated already, in part reflected that those changes that were coming on stream, the move to universal masking in various settings in the late spring, I think it was June of 2020 again, all of these things absolutely would help mitigate that. But right at the very start, when a lot of that was not available or in place, and of course when knowledge of the virus was at a comparatively early stage, the right thing, I think, to do was to say at this point we have to be firmer and we have to be more restrictive. But the principle always was to be less restrictive and more flexible as we learnt more about the virus, as other mitigations came into place.
We've touched there on nosocomial infection rates, and could we move on to look at NHS England's role in monitoring and responding to nosocomial infections in England? I think NHSE had established its own nosocomial infections programme, was that in existence prior to the pandemic?
Not in that form. Nosocomial infection, which is spread of infection within hospital and within healthcare settings more generally, is of course something that happens outside of pandemics. We're getting to winter at the moment, and norovirus, which circulates in the winter, is a good example of where spread can occur in hospitals. So hospital teams are well used to, through their IPC measures, to deal with nosocomial infection and to try and prevent it. So that experience was in place, but we didn't have a dedicated team around COVID in particular. That was set up actually as a subgroup of SAGE initially, the hockey group, which you've probably heard about, and then within a fairly short period of time came in with the governance structures of NHS England. And the nosocomial programme essentially was overseen by hockey and was part of the same programme of work. So we recognised very early on at the end of March that nosocomial infection was a problem. It was highly likely to be a problem with something as infectious as COVID-19, and we very rapidly put in the oversight mechanisms to design approaches to try and reduce it, and also to support individual trusts in their approaches to reduce nosocomial infection.
What did the nosocomial infections programme identify as the main factors driving hospital-acquired COVID?
Well, the absolutely main factor was the prevalence in the community, which in a sense might seem obvious, but it was the case that the more infection that there was in the community, that was the time at which we saw the most nosocomial infection in hospitals.
But how was it particularly spreading once it got into the hospital?
Well, it was, as I've said, I think the evidence is it could be spread through a variety of routes. A lot of spread was patient to patient, but it could also be staff to staff. And of course, staff meet together in lots of environments. It's not possible when you're working to separate completely, even with social distancing rules in place. So staff to staff could be a problem. We've talked about visitors to staff. So every possibility you can think of. And of course, there are mitigations for all of those. But you will never, in my view, be able to completely mitigate nosocomial infection. Of course, the other thing to say in this context is the nature of the hospital estate is really important. So many of our hospitals are older and they have more open wards and few single rooms. I have said in public that I think, and I think here's a recommendation for the inquiry, that future hospitals should be predominantly single-roomed. There are a number of reasons for that, but one of that is around infection prevention and control. That is the case in many other countries around the world. Ventilation is important. There's a whole host of things in terms of our estate that will increase the risk of nosocomial infection.
Is it right that testing of both patients and staff was also identified as a key measure?
Sorry, I missed the start.
Is it right that testing?
Yes, correct.
Patients and staff was identified as a key
yes, it is correct.
measure?
And when testing became available in higher quantities, we first introduced testing of all patients in hospital at various points as a way of identifying patients who had got nosocomial infection, who may not have come in and had possibly come in with an infection from the community. And then later on, we introduced staff testing on a regular basis once we had the capacity.
If I can introduce, I think this is right in terms of the timings. I think it was in June 2020 that a policy of testing all emergency admissions was introduced, and then testing all inpatients on day 3 of their admission was introduced on the 17th of November 2020. So if those patients may have developed COVID whilst they were in hospital.
So that's correct. So of course we had to determine how often to test in hospital, and so colleagues at Public Health England helped us with that sort of modelling, and we iterated our thoughts on that as to the most effective time after a patient had been admitted to test. So that was the evolution of that approach. And also, of course, testing was becoming more available as we went through into the latter months of 2020.
I think regular testing of asymptomatic staff was introduced at the time of greater availability of lateral flow devices in early November 2020. Is that right?
And that's correct. And indeed, that was a game changer, if I can use the term game changer, because it was the availability of lateral flow tests in volume that allowed us to have the quantity of testing that we would need to test all NHS staff.
Notwithstanding the various measures that were taken, you've identified that in summer of 2021, probable or definite hospital onset cases averaged 10% of all hospital COVID-19 admissions in England. So does that mean that 10% of all patients in hospital with COVID at that point had acquired that infection in
Yes,
hospital?
correct.
And you've also noted that nosocomial transmission increased notably with the more transmissible variants. Could we have a look, please, at paragraph 464 of your third witness statement? That's page 127. Thank you. You explained that the rate increased with the emergence of the more transmissible Omicron variant. In the first months of 2022, the percentage rate of probable and definite nosocomial infections increased to between 25% to 35%. This was due to a combination of Omicron's increased transmittability, its vaccine and immune escape properties, and greater numbers of non-COVID-19 patients in hospitals, allowing more infection transmission opportunities for the virus. And if we can go on, please, to paragraph 465. Omicron's comparatively lower impact on morbidity and mortality meant that the return to enhanced IPC measures, as seen in previous waves of COVID-19, was not required and not implemented. That may seem to some a rather relaxed approach to increased nosocomial transmission rates, given that the Omicron virus still proved fatal for some patients.
And this is a balance of risks. And as stated in those paragraphs, by the time we got to Omicron, it was clear that through a combination of the immunity that had come from the vaccination program and prior infection and potentially Omicron being having less clinical impact, part of the properties of that variant, it was really clear that Omicron was not causing the degree of harm to the population as a whole, to individuals, as the Alpha wave and the original Wuhan wave. So at that point, we had IPC measures that had evolved, and again, flexibility for local systems to adapt their IPC measures, and the decision at the time was that that would be the appropriate stance to keep, to give that flexibility to local systems. But there's always a balance here between understanding what the virus is doing and the potential consequences and the impact of IPC measures. And IPC measures, of course, do have an impact. They have an impact on the ability to flow patients through the hospital because you have to separate patients out, so you lose bed capacity. So all these measures are not without downsides and risks, and that's why it is always best thinking about this as a balance of risk.
Thank you. We can take that down, thank you. New topic, please. Pulse oximetry to monitor COVID-19 patients, and particularly the NHS England COVID oximetry at home programme. I think it's right that that programme was run through general practitioners providing pulse oximeters that have been supplied by NHS England to patients with COVID-19, and it was available to patients who tested positive, were symptomatic, and were aged over 65 or clinically extremely vulnerable. Is that right? The inquiry has heard about concerns that pulse oximeters may not be accurate in patients with darker skin pigmentation, and I think those concerns were first raised during the pandemic after an article had been published in the British Medical Journal on the 21st of December 2020, which was itself based on an American journal report. Is it right that NHS England published a COVID oximetry at home operational update on the 23rd of December 2020 in relation to those concerns?
Yes, correct. Immediately we heard of those concerns, we responded to it.
And what was the advice given in that update? Well,
the advice was to note that these concerns had been raised, to emphasise that pulse oximetry should be used in the context of other things, so symptoms, signs, other signs that the patient might be displaying of deterioration, that absolute readings of oxygen levels through oximeters were maybe not as important as looking at a trend, so a falling trend in readings rather than an absolute trend. This is information that had gone out at the start of the programme, but we felt it was important at that stage to acknowledge that concerns had been raised, but also to emphasise that oximetry purely on its own, in other words, taking a single absolute reading, was only part of the oximetry at home programme, and there had to be a wider view of the patient as well. And of course, for the patient to take account of other things that were happening rather than just the oximeter reading.
So is it right then that even if there had been a degree of inaccuracy in terms of the reading that was given by the device, if there was a drop in oxygen saturation levels, blood oxygen saturation levels, the device would pick up on that?
But yes, that was our view, and our risk was that people amongst communities with darker skin would be put off from enrolling in this programme at all, and therefore would not get any benefit from it because they may be worried about inaccurate readings, where in fact what we wanted was a programme that was more holistic than simply a reading of a single oxygen or a set of absolute oxygen levels. So that was the balance, and that was the fear, and that was why we issued that guidance to ensure that our clinicians and patients using this understood that there was a constellation of things that you needed to take into account.
So if we can move on a few months from NHS England publishing that update in December of 2020, towards the end of March 2021, the Race and Health Observatory published their rapid evidence review on the potential for inaccuracies in pulse oximeter readings. And they raised this concern that given the increased mortality amongst ethnic minority patients during the COVID-19 pandemic, it is possible that the differential accuracy of pulse oximetry is a contributing factor to this health inequality. In other words, that reliance on inaccurate pulse oximetry readings could have led to higher mortality rates from COVID-19. What are your views as to whether that is possible, that potential inaccuracy could have led to increased mortality? So
I understand the potential risk, but I haven't seen any evidence, and I think others have not seen evidence either. I think this was mentioned in the report that was commissioned from the Secretary of State into the use of pulse oximetry and other devices, that we have no evidence that any actual harm has resulted from this.
Has anyone looked for any evidence? Have there been any evaluations of the programme?
Well, there are ongoing clinical studies at the moment. In one of the very first pilots that we did way prior to December 2020, we targeted for inclusion individuals from those communities because we knew they had a higher risk of COVID, and we didn't see any adverse outcomes. I don't believe that we've seen any adverse outcomes, but clearly ongoing research is needed in this area. There is ongoing research. I'm also aware of some concerns around the methodology of some of those original articles. NIHR are undertaking some research at the moment to try and replicate the data and bring it more up to date. So this is an area of ongoing research where I think there is still some uncertainty.
You mentioned the briefing note that was prepared for the then Secretary of State for Health and Social Care, that was Sajid Javid at that time. Can we go to that document, please? It's INQ 000470551. Did you have input into this?
I don't think I did.
We can see that there's a summary has been prepared there. We're not aware of any evidence that pulse oximeter inaccuracy in people with COVID and darker skin has contributed to excess deaths. The Medicines and Healthcare Products Regulatory Agency is not aware of any incidents where skin colour has had an adverse effect on the use of pulse oximeters when providing effective clinical care. And it references the NHS guidance about monitoring trends and says it's asked the National Institute for Health Research to commission rapid further research. Is that the research that's not yet?
Yes, so I have checked on that recently, and the end date of that research study was due in August this year. I understand that the team have been granted a short extension, so we are still awaiting the output of that research.
And at point 6, it says we're concerned that some media messaging risks increasing numbers of people with darker skin who decline pulse oximetry services, thereby exacerbating inequalities. And if we can go down, please. Point 8, there are some research reports that pulse oximeters may not work as well in people with darker skin. And is this the concerns that you mentioned about the quality of that research? The reports involve old out-of-date oximeters and/or there's no detail on the specific models used. They involve relatively low numbers of patients. No studies have involved COVID patients. They involve reading levels unrelated to the ranges set out by NHS COVID oximetry at home, significantly lower, which would mean the patient would likely be hospitalised. And there are questions over the validity of testing based on commonly accepted methodology, so time delays between comparing the oximetry readings with, I think it says below, can we scroll down, please?
Yes, those are the methodological issues that have been raised. But this is clearly an important area. I mean, it's one that we absolutely need research on, and we absolutely need to ensure that the devices we use within medicine, not just pulse oximetry, are fit for uses in all people.
Can we go to the second page of that document, please, Lawrence? Thank you. I think we can take that down now. Subsequently, I think on the 21st of November 2021, the Secretary of State of Health and Social Care expressed concerns on the Andrew Marr show about these inaccuracies and said that he thought it was possible that black and minority ethnic people may have died from COVID-19 as a result of relying on inaccurate pulse oximetry readings. Can I ask you what your views were at the time of how helpful those comments were from the Secretary
well, I
of State?
can't recall exactly at the time. I mean, clearly we were concerned because, of course, the reason for putting this programme in place was we were worried about silent hypoxia, worried about patients who were deteriorating without symptoms. That was the rationale right at the start. And therefore, we were worried that if people didn't take up this offer, they could deteriorate more quickly than would become apparent from their symptoms. I think on reflection, I wonder whether he based those comments on the Race and Health Observatory comments. But I do note in his evidence statement to this module that he has noted that there has been no evidence and that the commissioned piece of work that he asked for states that there has been no evidence of harm. I should also probably note in this respect that there were a number of evaluations and there have been a number of subsequent research studies into the use of pulse oximetry at home. This is in all populations. Those studies are fairly mixed in their conclusions, but they tend towards either a neutral effect or a positive effect, and I don't think any of them have determined that harm came from this programme.
So this is in relation to using pulse oximetry to monitor COVID patients?
Yes, at home, yeah.
Thank you. So some have shown, I think, some benefit in reduced mortality figures and some have shown no difference.
Yes, but I think none have shown harm.
Thank you. If we can move on, please, to 111 services and telephone triage for COVID-19 patients. What was the involvement of NHS England with the 111 service? What's its role in
We oversaw the 111 service during the pandemic. 111 services are commissioned locally, but this is an area where we took a more direct role as part of our level 4 response.
Is it right to say that particularly at the beginning of the pandemic, the 111 service was struggling to respond to the volume of calls it was receiving?
As we got into late February and March, we had particular trouble responding. That was at a time where there was a lot of concern around obviously what was going on in northern Italy, the likelihood that the pandemic would come here. Although there weren't many cases at the time, there was a lot of public interest and a lot of desire for information. So we were seeing requests coming through, both asking for general information about COVID, but also specifically around worries that an individual might have symptoms of COVID-19. And so a variety of different services were stood up. Important to remember in this respect that, in a sense, 111 is a number, and there are a set of different services that can be flexed that sit behind that number. So 111 itself is the telephone number. What you are directed to afterwards can be a variety of different services, and they can flex and change depending on the context.
Can we go to a graph that you have provided at page 216 of your witness statement? This is the number and percentage of calls answered within 60 seconds. The dotted line at the top, I think, is the target rate. And we can see that calls received are in green, and there's a big spike in March of 2020. Calls answered in light blue is calls answered, and in dark blue, calls answered within 60 seconds. We can see there's a corresponding dip in March of 2020 in relation to the number of calls answered. You've explained that I think additional call agents were added to the core resource in, first of all, February 2020, another 150 call agents, and then another 117 full-time equivalents were agreed in March of 2020. How long would it have taken for those additional staff members to be recruited and to take up their posts? Well,
the training for the 111 service takes a number of weeks, I think 5 weeks. And so very early on, in February and going of 2020, we took the decision to stand up a standalone service to deal with patients and individuals calling in with concerns about coronavirus, and that was the COVID-19 response service, the CRS. And one of the reasons for doing that was because we could ensure that service was really just targeted on COVID-19 rather than the complete range of conditions that anybody might call 111 about. It meant that the individuals that we recruited to that service didn't require the length of training that they would to get to become part of the general 111 service. So rather than knowing that it would take time to train people to deal with all circumstances, rather than focus on expanding the 111 service, we set up a separate service that could deal specifically with COVID, and that had the advantage that the training was shorter. Remember, the call handlers in 111 and indeed the CRS are basically running to algorithms and scripts. They're not clinicians. They are asking a set of questions which will lead to a particular action in terms of advice to the patient, or whether the patient is referred on to 999 or to a clinician. And so the algorithms that are needed just to deal with a single set of symptoms in a condition, COVID-19, is far less complex than the algorithms that are required for the whole range of conditions that anybody could phone out 111 about. So that was the rationale.
And those additional staff that I mentioned in February and March of 2020, were they recruited to the core 111 service?
They were in the 111 service.
Rather than the CRS?
Yes. But the reason we didn't expand beyond that was because we focused our efforts on expanding the COVID-specific COVID response service. Public Health England had also set up a helpline, which was predominantly around giving general advice around COVID. And I think you will probably see, you might show me an exhibit in a minute, that there came a point where that service was essentially doing the same as the COVID response service, and so we asked PHE if we could merge the two services into one.
Perhaps we can get at that document. It's INQ 000348589. This is a briefing document dated the 26th of March 2020 from Public Health England, following discussions about that merging that you've mentioned. And can we go to page 3, please? In response to a request from NHS England, NHS 111 for aid, Public Health England sourced an additional 1,000 call handlers at 24 hours notice to support 111. These call handlers now provide provide capacity as part of the NHS 111 COVID-19 response. Is that the CRS?
I believe that is a CRS, yes.
So that was an additional 1,000 call handlers that were sourced at that point.
So this was essentially merging the PHE helpline, which at this stage in late March, I think calls had moved from general advice around COVID to more specific advice about individual circumstances, which actually was the role of the CRS, and therefore the functions that what practically was happening in those two call services was essentially duplicative, and therefore it made sense simply to combine it into a single service.
Can we go to page 2 of that document, please? There's a graph there at the bottom, if we can see the green and orange graph. Thank you. And this covers the period 27th of February 2020 to the 24th of March 2020. So it's a snapshot really of the daily figures over a period of about a month early in the pandemic. And it's the core service calls offered and answered. And I think we can see there that the green bars show the number of calls that came in, and the red bars are the number of those calls that were answered at all, even after 60 seconds. And so we can see that performance, as the number of calls comes in, actually the number of calls being answered is declining really from the 7th of March and declining throughout that month. The orange line, solid line there, I think demonstrates the calls answered within 60 seconds. So that's at times dipping very low. So looking at that snapshot, it seems that the system was struggling to meet demand at that time. Was the problem there insufficient call handlers?
Well, the problem was the level of demand. It was obviously a mismatch between supply and demand. It was one of those occasions that a part of the service did absolutely face a situation where demand was greatly exceeding supply. This is the granular detail, I think, behind the chart that you showed earlier. And in March, we were seeing double the number of volumes of calls into 111 that we would have done in a equivalent month pre-pandemic. So there's no doubt that there was a huge amount of pressure coming on, and it was really difficult to cope. The mitigations were to produce that, to instigate that COVID response service, which we at the time felt was the most effective and quickest way of taking some of the pressure off 111. In time, we also put in place a COVID clinical advice service, which provided clinical support into the call handlers. So there were a number of mitigation strategies, but there is no doubt that the NHS and NHS 111 in this particular period was under extreme pressure, and it's reflected in these graphs.
If we can come back to this graph, we're not seeing a constant level of the number of calls answered through this month. And so when we get to the 16th, 17th, 18th to the 20th of March, the numbers have dropped to well below 20% of calls being answered altogether. And when we see the numbers of calls down the side, it seems that fewer calls are being picked up, doesn't it? Not just that demand is increasing, but
yes. Well, we're heading into peak numbers of or peak prevalence of COVID in the community in wave 1. So 111 was incredibly busy at that time, and this reflects the pressure. I can't reflect on why one day was significantly different from another. But I think the overall picture, as you showed in that earlier graph, was that this was the period where we had sustained pressure on 111, as did other the devolved administrations as well in their services.
I think we can take that down now, thank you. Perhaps we can move on from the statistics to the quality of the calls. I think it's right that the Healthcare Safety Investigation Branch undertook an investigation into concerns about patient safety issues.
Yes, they did.
In response to callers to the 111 service. That report was published in late September of 2022.
Correct.
And it noted that the clinical staff recruited to work in the COVID-19 clinical assessment service reported to HSIB that they had received very little in the way of clinical training, and they'd established informal networks to try to share knowledge of the virus. Was NHS 111 aware of those difficulties with the level of training that had been offered?
Yes, we were, and there was a strategy behind this, which was so the clinicians recruited into that service, the COVID clinical advice service, were mainly GPs, active GPs or recently retired GPs, and the intent was to provide a clinical support for the call handlers. The intent was not to recruit a group of clinicians and then train them in additional clinical skills, because what we wanted to use was their general skills, which they already had around identifying patients who were deteriorating, patients who might have conditions that were other than COVID-19. So our view was that we didn't need to train them in a set of clinical skills that they already had. What we did need to train them in was telephony and how to work in a call centre, whether it was home or wherever, and in the 111 service. So the training was short. It was telephony specific. If there were updates to the way COVID-19 was being managed, then that was communicated, but it was deliberately not the intent to spend a large amount of time training them in a set of skills that we felt they already had, which was the reason for bringing them in the first place.
In retrospect, and with the benefit of hindsight, do you think there might have been some benefit in, given that these are trained clinicians, if they were given some targeted training around the clinical presentations of COVID?
I believe they were, but obviously you've heard those reflections in the HSIB report that not everybody felt that it was what they needed. So I think that is definitely a reflection for the future, but it was definitely the strategy to bring in a group of clinicians to use their existing clinical skills, which would be generalist skills around identifying patients who were deteriorating, patients who had a set of symptoms that might or might not be COVID-19. So yes, of course, we always reflect on these things, but the strategy was to bring them in for their skills, to give them the additional telephony training, not spend weeks teaching them something that we felt that they already knew and was the reason we were bringing them in the first place.
That report from the Healthcare Safety Investigations Branch made a number of recommendations directed at various bodies. One of those recommendations was that NHS England should review the risks associated with increased use of telephone triage services during a national healthcare emergency. And I wanted to ask how NHS England has progressed with that.
So I think that work is being undertaken with colleagues at UXA. I haven't got an output for you at the moment, but we have been looking at those recommendations. There were a number of other recommendations as well around call recording, if I recollect correctly, which we have also been, on the call recording that was implemented pretty immediately, but there are a number of other reflections in that HSIB report that we're working on.
Aside from the HSIB report, I think you have been made aware of a report in The Guardian from October 2020 referring to what was called an internal audit of 111 that noted that up to 60% of calls handled by the clinical assessment service within 111 were rated as not safe, and what steps NHS England took in relation to that.
So this related to nurses who were a very small part of that overall cohort of clinicians. As I said, the clinicians in the COVID clinical advice service were predominantly GPs. The service, if I remember, was hosted by SCAS, South Coast Ambulance Service. The audit, I believe, was an audit that they undertook, a relatively small sample size, raised those concerns around the quality of information provided by nurses. That was raised with NHS England, and we took the decision that we would remove nurses from that pool of clinicians.
Thank you.
Could I just add, because I should have added this, that there were a number of other clinical advice services for dentistry, for example, that were stood up. And of course, the clinicians in those services had the clinical skills relevant to the particular service. So obviously in the dentistry clinical advice service, it was dentists. And again, we didn't feel that we needed to reteach dentists a set of skills that the dentists already had. That was a reason for bringing them in the first place.
So I'm sorry, I didn't follow your answer. Neil put to you that a large percentage of the calls were found not to have been answered satisfactorily. And I think it was 60% of the
Up to
calls.
60%.
And then your answer was that related to nurses who formed a small part of the team. Could you explain?
So this relates to a report in The Guardian that there was a quality issue in the COVID clinical advice service amongst the cohort of clinicians that were nurses. It was a small number of nurses in that service, in that cohort of clinicians, mostly GPs. And I think the audit undertook an audit of a small number of them, but it showed that there was, I think, 60% issue. It was an issue of about 60% of incorrect advice or incorrect process. And as a result, we decided it would be best to remove nurses from that pool. But the majority of that pool of clinicians were GPs. So a quality issue was raised. We responded to it appropriately.
But the quality issue was raised only in relation to the quality of advice that was being given by nurses.
Because I think that was what the audit. I think that was what the audit. That was where the concern had raised. Yes.
Thank you. If we can move on, please, from 111 to care for or maintaining care for conditions other than COVID-19 during the pandemic. You've explained that in your witness statement that some core services such as maternity care, urgent and emergency care were never paused, but the delivery of those services was adapted or reorganised for the pandemic. Is that right? And you give the example of ambulance services, which established alternative pathways to ensure that frontline ambulance resources were optimised for the most seriously ill and injured patients. And I'm asked to ask you or clarify with you whether that meant that the 11 NHS ambulance trusts relied upon independent ambulance providers to provide some services, particularly in relation to non-emergency patient transport. So were they then playing a bigger role?
There was some use of the independent sector, as there was generally. And
given the greater reliance on the independent ambulance sector during the pandemic, do you consider that in any future pandemic, independent ambulance providers should be consulted prior to the final formulation of measures and guidance that affect the ambulance sector?
Yes, ambulance service is not my area of expertise. I believe you have taken evidence from my colleague Anthony Marsh. I would think that would be sensible, but again, not my area of expertise.
Thank you. Maternity care, you mentioned as one of those core services that could not be paused but had to be reorganised to some extent during the pandemic. Can I ask you this in relation to maternity services specifically? To what extent do you consider that maternity care professionals should not be redeployed to other services during a pandemic? Firstly, because maternity care is an essential service, and secondly, because training in maternity care is highly specialised.
I agree with that.
Your statement makes clear that during the pandemic, discharges from maternity units were more rapid, discharges of new mothers were more rapid, with shorter postnatal stays on average. Do you consider that those shorter stays could have resulted in a reduced quality of care and support provided to women immediately after childbirth?
Well, I would assume and hope that the clinicians who were discharging women after birth were doing so safely and were expediting the discharge process without taking undue risk. That's many ways in which you can expedite discharge without causing harm. I have no evidence that harm was caused, but I would have I would expect that clinicians would not want to discharge somebody unless they felt it was reasonable for them to be discharged and or they had the appropriate support in home that meant that some of the support they might have had in hospital could be replicated at home.
And you've set out in your witness statement the way that the maternity care service did change in a number of ways. Some midwife-led units were closed temporarily during the pandemic. Certain services weren't made available as they had been previously. Do you have any reflection on the changes to maternity care during the pandemic and any lessons that you would learn for future pandemics?
Well, we've talked about visitor guidance, so we've covered that off. We've talked about the not redeploying staff out of maternity units. I think it was right to look operationally at whether there were smaller units. Of course, one of the problems with smaller units is that they have smaller numbers of staff, so any outbreak of infection means that they are vulnerable to disruption or closure. So I think we would take that approach again. Then I think you are into much more general issues around how we support staff and how we support patients in our services as a whole.
Thank you. If we can come on, please, to elective care. I think it's right that during the pandemic, elective or planned care was paused from the 17th of March 2020, following which NHS England encouraged those trusts who were able to do so to consider resuming elective care in late April of 2020. And then on the 31st of July 2020, NHS England instructed trusts to recover the maximum elective activity possible, including using independent sector
Yes.
capability if that was necessary. And you've set out some of the strategies that were adopted to maintain non-COVID care. I'd like to deal briefly, if I may, with each of those in turn. Firstly, the increased use of technology in primary and secondary care for patient consultations. We've heard some evidence about the challenges of delivering remote consultations. Do you consider that NHS England provided sufficient guidance for clinicians to enable them to appropriately identify patients or symptoms which require direct in-person assessment?
So we did provide a lot of guidance, and I think important to say that this was a direction of travel that predated the pandemic. In the NHS long-term plan, which was published at the beginning of 2019, we set our ambition to move in the hospital sector a number of outpatient appointments from face-to-face to remote appointments. The reason for doing that is because technology is now at a stage where it's possible, and of course, where a face-to-face appointment and examination is required, then an appointment should be undertaken in a healthcare setting. But there are plenty of opportunities to do that remotely. When I was a practicing clinician in my days looking after kidney transplant patients, I often reflected that sometimes I could have had a telephone call rather than bringing somebody into hospital, because the discussion that we needed to have didn't need an examination. It was maybe a discussion of results that had become available. So that was a direction of travel, and we were doing work on it. Indeed, I well remember in the month, probably in the February of 2020, going to one of the major hospitals in London who were starting their programme of moving outpatient appointments more remotely, seeing a sea of sceptical faces, and then 2 months later somebody from the hospital saying, we actually did it all in a week when we had to in the pandemic. So there was a lot of groundwork in advance. But clearly the move to it was very rapid. It had to be because of the circumstances. And there are some downsides of moving that rapidly, within which I would include taking the public along with you in terms of the change of service. But it was the right thing to do under the circumstances. In primary care, of course, we did the same. Again, there has been a move over the years to a mixture of face-to-face and remote appointments. In general practice, where again it's back to the issue of smaller healthcare settings with smaller number of staff, if there is an outbreak in that setting, then the entire service goes down. We saw that in the early days of the pandemic where we had to close GP practices. So this was again a balance of risks. We had made preparations in advance. We had to accelerate those. We issued a lot of guidance. Yes, we could always do more, but it was, in my opinion, the right thing to do.
You mentioned some of the downsides, which brings me on to my next question, which is about the potential for some patients to be excluded from access to digital or remote engagement with healthcare. Do you think that risk or that downside was adequately addressed by NHS England?
So that is a concern in pandemic times and outside pandemic times, that we don't digitally exclude individuals. We have to be very careful to ensure that we give patients routes to access that they want and that it's appropriate. So it's very much on our mind. But equally, I've always felt that the use of digital technology actually can be a benefit for more vulnerable groups, because actually coming into hospital can be quite a challenge, and the advantage of not having to come into a hospital healthcare setting is often an upside as well.
Is that a convenient moment?
Certainly.
You sure?
Yes.
20 past.
Professor Powis, we were on the subject of elective care and strategies to maintain elective care during the pandemic. And the inquiry heard last week from Professor Anil Bangu, who's an expert in colorectal cancer, and also from Professors Metcalf and Ms. Scott in relation to hip replacement surgeries. And all of those experts recommended an increased role for elective hubs that would be separate from hospitals with emergency departments and so on, which would enable protection of elective patients from the risk of hospital-acquired infections. Is that something that NHS England would support, greater use of creation and use of elective hubs?
Yes, and they are correct, and it is NHS England policy to do so at present. We had been doing that prior to the pandemic. Clearly, the pandemic re-emphasised the importance of separating cold elective care, non-emergency care from emergency care, and we have been proceeding with that policy.
Another of the strategies you've identified in your witness statement was the use of independent sector facilities. And the inquiry heard from Professor Bangu that had been very successfully utilised for cancer patients. However, in relation to hip replacement surgery, Professor Metcalf and Ms. Scott explained that only very small numbers of orthopaedic surgery patients were treated in private hospitals. So I'd like to ask whether you think that independent sector capacity was fully utilised during the pandemic, whether there was an issue about what type of care was prioritised for the independent sector, and whether there were limitations on the use of the independent sector, such as lack of staff.
Yes, it was right that we took the capacity of the independent sector during the pandemic. It provided that flexibility we required. It wasn't just the facilities of the hospitals, it was the staff, it was the equipment that became available too. Clearly there were challenges, as you have said. It is quite right that often the same staff who are undertaking procedures in the independent sector are the NHS staff who are undertaking work in NHS hospitals, and they clearly cannot be in two places at once, and they may have been redeployed into COVID activity. So undoubtedly that was a challenge. There was variable uptake across the country, very dependent on local configurations and local availability. But in general, we are very grateful to our colleagues in the independent sector who supported and lent their support. Clearly there were contractual underpinnings to this, but we very much worked closely with them and worked as one to address the challenges of the pandemic.
Finally, on non-COVID care, screening, or what Professor Bangu referred to as anti-diagnostics, it was Professor Bangu's recommendation that screening should continue and not be paused in the event of a future pandemic. Would you see any reason not to continue with cancer screening programmes in a future pandemic?
So we didn't at national level turn off or step down screening services, but we are well aware that there were decisions made at local level to do that. Quite understandably, in the face of the pressures around the peaks and depending on the screening service, redeployment of staff. So all services came under pressure, and we try to protect screening services as much as possible and then recover the lost ground as quickly as possible afterwards. But in general, I agree, we would do as much as possible to preserve screening services during a future pandemic.
So cancer, you say you try to recover as soon as possible, but it could be too late.
Well, this is in respect to screening services, so there's a
But if the
range.
cancer has progressed because no screening is...
Oh, absolutely, and that would be the reason for wanting to protect screening services. In fact, we recovered at various rates, depending on the particular screening programme. The screening programmes that probably gave the greatest challenge was endoscopy, which we use in some of our follow-up to screening programmes. But yes, in principle, we would try and protect screening programmes as much as possible.
In terms of the number of patients presenting for non-COVID care, including elective care, you've noted in your witness statement that the impact of the stay-at-home protect the NHS messaging may have played a part in the significant decrease in people coming forward for healthcare. What lessons do you think can be learned about balancing that sort of public health messaging and ensuring continued access to healthcare for individuals who need it?
Yeah, well, the Protect the NHS message, which was a Cabinet Office developed communication strategy, I think was the best intent. It was to recognise that people were sacrificing great sacrifices in terms of social distancing and lockdown to ensure that transmission rates dropped and that relieved pressure on the NHS and, of course, reduced deaths. But, of course, unfortunately, some people might have interpreted that as stay away from the NHS, which was absolutely not what we wanted. We were quite clear that if you had a condition that required NHS treatment, you should come forward. So early on, we began to get worried about the risk of that happening. I raised it and spoke about it deliberately at a very early stage in one of the Downing Street press conferences. I think it was the 4th of April or thereabouts. I stood up and actually I remember getting an email from somebody afterwards saying, my husband was been sitting at home for a number of days, I think with the chest pain, I think it was, and wouldn't go to hospital. And they heard you on the television, and he went, and they saved his life. And so I know it had an impact. I won't get emotional here, but that was the yeah. So we were worried. We communicated those concerns to the Cabinet Office, and we introduced the Help Us, Help You campaign, which had a number of different iterations around cancer symptoms to remind the public that the NHS was there. Please do come. But understandably, people were worried. They were worried about catching infection in healthcare settings. They were worried about, disrupting the work of healthcare professionals, which, they didn't have to be. We really wanted them to come forward. And that is a lesson learned for future pandemics, that we need to do as much as we can to ensure that people know and have the confidence to come forward.
Were the NHS involved in developing the messaging, or was it just the communications or...
No, we weren't.
To
my knowledge, we weren't. And as I said, we have no doubt it was done with the best intentions for good reasons. And it was an effective message in the sense of social distancing. But there was a concern that people might be misinterpreting that. I think there were a number of other reasons why people stayed at home, which they undoubtedly did. We saw falls in the number of admissions for a number of conditions. And of course, we were very quickly on to trying to remind people that you should come. But it is one of the things to reflect upon for future pandemics.
Do you think, picking up on her ladyship's question, do you think if there had been some involvement of NHS England or senior healthcare system leaders when formulating that Cabinet Office messaging, that perhaps a slightly more nuanced message might have been possible?
Perhaps, but easy to look backwards in hindsight. I think the important thing is to think about it going forward.
Can we move on then, please, to the role of NHS England in commissioning services for long COVID? You've set out the chronology of events in some detail in your fourth witness statement. So can I take you, please, just to some of those key developments? I think it's right that NHS England commissioned NICE to develop evidence-based guidelines and treatment options on the 30th of September 2020. And prior to that, there was support available to people experiencing long-term impacts of COVID via the online portal Your COVID Recovery. which was launched in July of 2020. And then there was an interactive tool available on the same platform from the 7th of October 2020. Is that right? The Chief Medical Officer, Professor Sir Chris Whitty, suggested when he gave evidence at this inquiry that we could have been swifter off the mark in spotting long COVID as it emerged, and in commissioning health services for people with long COVID. I'd like to ask whether you agree with that, and whether you think NHS England could have acted sooner, for example, making the request to NICE prior to 30th of September.
So my view is that we acted very quickly in terms of our response to long COVID, and I absolutely acknowledge that from the perspective of those with long COVID, it is never fast enough. But compared to other services that I've been involved in standing up from a standing start, I think we acted quickly. I became concerned, as others did, as we came out of wave one and into the summer of July 2020, that many individuals were reporting long-term effects and symptoms following COVID. This was brought to my attention by Long COVID SOS, who wrote to me in early August, and I met with them on September the 11th, 2020, I think was the date, and I'm really grateful to those from Long COVID SOS who attended that meeting, because it was a turning point for me in terms of long COVID. I remember it in graphic detail, what they told me. They told me that they were having difficulty getting clinicians to believe or understand their symptoms and whether this was actually a thing, a condition. Sir Chris responded to this, and I agree that at that early stage, it's maybe not surprising that all clinicians didn't have the information they needed, but I absolutely understood the frustration of those who were suffering with long COVID. They also made a very important point to me as well, which was for many people who'd not been hospitalised, they didn't actually know for certain whether they'd had COVID or not, because of course the testing wasn't available. So there was the additional uncertainty of having a set of conditions which you thought was related to COVID, but you couldn't be 100% certain. They made it very clear to me that what they didn't want was to go from pillar to post from one service to another service, because they had a range of conditions affecting different parts of the body. They wanted a holistic, joined up service. And they wanted this to be a specific service. And so I went away with colleagues within my team. We developed the 5-point plan. I'd already been thinking about commissioning NICE to undertake a case definition. I wrote to them on the 30th of September, but I never write to NICE commissioning them to do something without contacting them beforehand to tell them I'm going to do it and ask them if they can. So the initial conversations would have been before the 30th of September. And of course, I asked NICE to do it as quickly as possible, understanding the constraints. We've discussed about doing something quickly, particularly when the evidence base was still emerging. And then we set about setting up a long COVID task force, which my colleague Kieran Collinson, the Deputy Primary Care Medical Director, set up, and she did a magnificent job in bringing patients and others together to have input into the services. And we had 69 long COVID clinics set up by December, which I think was faster than just about every country in the world. And although, back to what I said at the start, I know how incredibly frustrating this was and how quickly individuals wanted this to be done, but from my perspective, we did move quickly on this, and I'm very proud of the team that I had who worked so hard, both nationally and regionally, to get these clinics established.
You mentioned there that by December 2020 there were 69 operational clinics across England. I think by November 2021, 90 long COVID clinics and 14 paediatric hubs for long COVID. And I think by November of 2021, you've noted in your witness statement that patient feedback surveys showed high levels of satisfaction with long COVID services, but there was still wide local and regional variation in both referral rates and waiting times. And the waiting list stood at over 12,000, with 33% waiting more than 15 weeks. Are you aware of whether variation in services and barriers to access continue to be problems in England? And if so, are NHS England taking any steps in relation to that?
Yes, there are still problems around variation. Of course, as we've discussed earlier, it's quite right that we allow local healthcare systems to provide the services that they think are most appropriate for their patient population, their configuration of health services. That inevitably leads to variation in just about every service that we deliver. We shifted at the end of the pandemic from a national approach to a locally commissioned approach. So we handed this programme over to local commissioners, integrated care boards. These are services that are in the range of services that should be locally commissioned. And there's a technical reason too. They're not on the specialised commissioning list, which is a list of around 160 services that the Secretary of State designates as nationally specialised services. But there is variability. I do have a little bit of concern around whether that is too much variation, and we have asked our colleagues within NHS England are currently undertaking a stocktake of the existing service so that we have a better sense of where those services are. I think those services need to evolve as well. We have learned a lot about the management of long COVID, and of course this sits within a general field of post-viral conditions, and you will be aware that chronic fatigue syndrome, sometimes also referred to as ME, is another set of post-viral conditions, and I think over time there may be value in combining those services, and of course that will give us more resilience going into a future pandemic if we have a service around post-viral conditions, long-term conditions that is already established. So I would encourage ICBs to focus on this as an area. As you have said, there is still demand. The demand amongst children, I think, has dropped a bit, and there's a little bit of consolidation in those services, but there is still demand amongst adults, and it's important that we pay attention to that.
Can I ask about long COVID and healthcare workers? Does NHS England currently collect data regarding the number, age, sex and ethnicity of healthcare workers and NHS staff who have been affected by long COVID?
I don't believe nationally. We have issued guidance and support and help to staff, to organisations in general as to how to support staff with long COVID. Of course, those staff have access to those clinical services, and indeed one of the observations very early on when some of those early services were set up was that they were seeing colleagues, members of staff who were coming forward. That was, I remember one of my early recollections of realising, the impact this was having on the NHS workforce.
So do you think it would be useful to collect that data at a national level? To have a national picture?
Whether I would have to think about that, because of course we can collect data on a lot of things, and the question is ensuring that there's a purpose to doing that at a national level rather than a local level.
We've touched briefly on one impact on the NHS workforce. If we can broaden out our perspective on that, please, and turn to steps taken by NHS England to protect and support staff during the pandemic. If we could look first of all at steps taken to protect staff from COVID-19 itself, before we go on to consider the support for staff that was coordinated by NHS England. I think it's right that from the 29th of April 2020, there was a requirement for all NHS trusts to ensure that vulnerable staff had completed a risk assessment, a COVID-19 risk assessment, and guidance was provided to trusts to enable them to carry out those risk assessments and identify risk factors. Was there a standardised risk assessment tool available to trusts at that point with a scoring system to quantify risks, or did that come later?
There was a risk assessment process set out with the help of NHS employers in, I think, April or May of 2020. So whether that would be classified as a tool or not, I don't know. But there certainly was a standardised piece of advice that was distributed to trusts to help them in this process.
So was there uniformity in terms of the risk factors that were, specific risk factors that were
I
identified?
can't specifically recall if that was the case, and I'm aware from other evidence that there might have been a tool in use in Wales, but I haven't been able to ascertain whether there was similarities or differences yet, but I can certainly look at that.
I think Professor Bamra from the Federation of Ethnic Minority Healthcare Organisations suggested that the All Wales Risk Assessment tool, which was a scoring tool, and stratified risk according to that numerical score, it was suggested that that had been passed to NHS England and informed the tool devised for England that came out in September 2020. Would that accord?
We couldn't see, when I saw that evidence, I asked to see whether we could find a record of that, and we couldn't. That's not to say we won't keep looking. So at the moment, I'm not aware that that tool was passed through to us, but I can't completely rule it out, and of course we will search on your behalf if you wish.
Do you think that NHS England could have acted more quickly to ensure that staff were being risk assessed?
We acted quickly, particularly when we started to understand the risk profile of COVID, particularly amongst colleagues from our BAME community. But by the time we got to June and July, I think it was apparent to us that organisations were not rolling this risk assessment tool out or the risk assessment process out as quickly as we would have liked.
I think you undertook a compliance monitoring programme from that
July.
point, and we'll come on to that shortly.
Yes.
Can I ask you this? Was there any consideration given to ensuring that NHS trusts were undertaking risk assessments for outsourced staff, so not non-employees? Was that supposed to apply equally to all workers?
So again, my view would be that whoever is employing staff, they should, if they are working within the NHS community, they should be within the NHS community. I can't give you the detail. Again, we can come back to you with this if we have the detail on how many trusts took that view and how many didn't. But my own personal view is that we should have a broad scope for individuals who are working within the NHS.
Thank you.
So just your answer maybe wasn't that clear. So you're not saying it should be the outside employer, but the NHS because they're part of the NHS community? Is that,
I think you could probably in practice do it either way, but I wouldn't necessarily rule out doing it one way or the other. I think it depends a bit on the relationship of the employer, and there are staff that are outsourced in a variety of different ways and circumstances, and some of the outsourcing arrangements are closer to the NHS organisation than not.
And perhaps it would be easier if the risk assessment is being conducted in the workplace by the line manager, regardless of employment status.
I agree.
Can we get up, please, INQ 330885? This is the compliance report. I think that you were referring to it earlier. I think there were 3 windows when compliance was assessed. I think in July, August, and then September of 2020, if that's right. And if we could go to page 3 there, we see the table showing national averages of when BAME staff were assessed, at-risk staff, and all staff. And we can see that there's an improvement from window 1, window 2, and into window 3, with eventually 96% nationally of BAME staff having received a risk assessment by window 3. Yes. When only 73% had been risk assessed in window 1. I think it's right to say that there was also great variation in compliance noted between trusts. I think we might, I don't think it's in that document, but if we can go to INQ 0003300972 on page 10 of that document, please. This is within the London region. We can see it's a bar chart showing as much as 96% compliance in one hospital and as low as 14% compliance in another hospital in terms of risk assessing their staff. We can take that down. Thank you. And you've explained in your witness statement that this risk assessment compliance monitoring was a useful tool in covering a cultural gap amongst organisations And you noted that good practice emerged from organisations that deployed an empathetic, coordinated and risk-stratified approach, targeting high-risk staff and work settings coupled with a strong communications effort. Conversely, the process also demonstrated some staff feeling targeted, redeployed without discussion, curtailment of training opportunities, and in some instances being put on statutory sick pay. Did NHS England take any steps in relation to those negative experiences of risk assessments that had been reported?
So we had this focus, as I've said, and you saw that in the data from end of June, early July onwards, to try and support organisations to undertake more risk assessments, and you saw the result of that. As part, I know you discussed this with Dame Ruth around us shortening the time, particularly for vulnerable staff, in terms of our expectations. We established a risk assessment delivery unit whose job it was, or task it was, to support, to spread best practice, to work with those organisations that for whatever reason were struggling. So we did put more targeted support and work into this during the summer of 2020, exactly because we thought it was such an important thing to do.
Can we move on now, please, to look at how NHS England monitored and supported staff health and wellbeing during the pandemic? First of all, can you help us with this? How did NHS England hear from frontline staff during the pandemic and monitor their wellbeing?
Well, we heard through lots of routes. You know from other statements that a number of people who worked within NHS England worked shifts. Dame Ruth May, I think, described eloquently and passionately how she worked on the wards. I didn't, but I clearly had colleagues who did. I obviously and others stayed in contact with many of my former colleagues who were working. I had regular meetings with the Royal Colleges. Dame Ruth had regular meetings with the Royal College of Nursing and others. So we had information coming back through other clinical leaders who were in touch with their members. I met with the BMA regularly, who also provided me with information. Of course, we have staff surveys as well that I'm sure we'll come on to. So there was and of course, Professor Fong's visits, which you heard him describe a few weeks ago, which we supported as part of our EPRR response. Those were all incredibly important and powerful ways of us getting information back. And of course, I undertook visits as well. In the first wave, that was really difficult because of all the other work I was doing. But increasingly, I went out and I visited actually many vaccine sites, but many hospitals. And so that ability to talk directly to staff, to just, sit down, have a cup of coffee and relive the experiences or what they were concerned about, all of those routes in are important ways in which you get a sense of what is happening at the front line of patient care.
Can I ask you this? You speak about the different results that have come out in the, I think it's undertaken in October each year,
yeah.
the annual surveys that come out. Were there any messages coming out from that survey that contradicted or differed from the messages that you were getting from the Royal Colleges, colleagues working on the front line, and any of the other channels of communication that you've mentioned?
Not in general. You may be about to show me some exhibits, but we instigated a separate survey, I think the People Pulse survey, which was a much more regular survey, and if you look at anxiety levels, they corresponded with the peak of the two initial waves.
Perhaps we could have a look at that. I think this was a monthly survey. It was a monthly survey,
so
it wasn't getting quite as many responses as the annual survey. But perhaps we can have a look at INQ 000330944 on page 2, please.
There we are.
So we can see plotted in blue, this is anxiety levels, and in grey, this is the number of COVID-19 patients in the UK. And so we can see at times of peaks in the number of patients. There's also peaks. The high point of anxiety there is 40.5 staff reporting that they're feeling anxious, and that declines as the wave of patient numbers declines as well.
So that's... Oh, sorry. That's perhaps not surprising, but I think there was a difference between wave 1 and wave 2, and I very much heard that from staff. So in wave 1, where this was, this was the first time staff had to deal with COVID, there was a great sense of camaraderie, a great sense of coming together and working out how it should be done. I think you might have heard a sense of that from some of the impact witnesses. Staff were redeployed into areas that they might not have worked in for a while, but there was this real sense, there was the public clapping and the public support. I think by the time it came to the second wave, or the second big wave, the alpha wave, there was a sense of, here we go again. This is going to be more difficult. We have learned to do this a bit better because we knew we'd gone through it once, but we really don't want to go through it again. And I think that was reflected in what I was hearing from staff. By the time you got to the Omicron wave, and again you could see this I think in the anxiety levels in this report, because that had less clinical impact and was in a sense more manageable, I think there was another, that wasn't as hard as it might have been. So I think it very much depended upon the wave and the stage of the pandemic you were in.
Can we go to page 5 of this document, please? Because there's a graph there that sets out anxiety and motivation. And we can see it's a sort of mirror image. The blue line, the bottom line, is anxiety, reported anxiety levels, and the orange line is motivation, as reported by staff. And we can see that as anxiety rises, motivation dips. Can I ask you this, as a clinician, what do you see as the potential clinical impact of a demotivated workforce or section of the workforce?
So there is no doubt that for everybody, as I've often said in public, who went through the pandemic, it was the most challenging, the most difficult, the most stressful time of their professional careers. It's the biggest health emergency in 100 years, the biggest challenge, crisis that the NHS has had to face since its inception in 1948. Staff were magnificent. They went the extra mile, but that was at a cost. And both at the time and both with lasting effects, it has deeply affected members of staff. We are very aware of that, and that is why we are trying to provide ongoing support. That will take time to get over, despite all the efforts. The risk assessment process, all the support that we put on really early was to help local organisations who are, of course, at the front line of helping staff to provide that support. But with an emergency of this sort, you can't fully mitigate it. I should also say, and you heard this very graphically from Professor Fong, if the NHS had got to the point where it was completely overwhelmed, it would have been even worse. The moral injury would have been, orders of greater magnitude. But having said that, even what we had to deal with had a huge impact on staff.
And I think you explained that the 2022 staff survey indicated that 34% of staff said that they always or often felt burnt out because of their work, and 37.4% often or always found their work emotionally exhausting. Is it right that incidence of burnout amongst the NHS workforce is reflected in difficulties recruiting and retaining staff?
I think it certainly impacted on retention, although actually we are doing reasonably well in terms of staff leavers at the moment, and we are getting to a better position. I think in recruitment we saw a real flush of people wanting to come and work for the NHS during the initial phases of the pandemic. That has dropped off a bit, and of course, you can never know what the impact of having more people coming forward would have in the subsequent years. But obviously a happy workforce, a workforce that feels supported, is a workforce that is likely to stay and be retained. And that's why a big focus of our work at the moment is in supporting staff. A big part of the long-term workforce plan that I think I referred to earlier is around retention of staff and ensuring that we support staff and have the conditions to ensure that they stay, and giving them flexibility of working, which of course is something that I think younger generations want much more now than perhaps people of my age wanted when we were going through careers. The annual survey, the October 2021, did actually show an increase in people who felt supported in health and wellbeing. I think that was at the time we were doing the big push on risk assessments. Difficult to know if it's cause and effect, but that was the case, and then it dropped off again in the October 2021 survey.
So can we move on and look at the support for staff that was provided for or coordinated by NHS England during the pandemic rather than currently? Yes. I think it's right, normally that sort of health and wellbeing support is provided at a local level rather
Correct.
than through NHS England. But during the pandemic, NHS England did take a lead role in expanding provision of health and wellbeing support. And you set out in your third witness statement that in terms of support for psychological wellbeing of staff, this took the form of mental health helplines, mobile apps, guides for managers on how to support their staff, the creation of virtual common rooms for staff
Yes.
to share their experiences, and the provision of physical safe spaces and rest areas. And that included specific health and wellbeing support for BAME colleagues. And you give the example of Tagalog-speaking bereavement counsellors for Filipino staff. What was the uptake of the health and wellbeing support that was offered, and what was the feedback from staff on the usefulness?
So I don't have those figures in front of me. I can certainly provide them with you. They might be in my statement. I would need to have a look. I think they were generally well received. The aim, as you said, was to support local organisations who have prime responsibility as employers for their workforce. So again, going back to being in a level 4 incident, one of our tasks here is to provide that national resource to support those local organisations, and we did that entirely as you described through a whole range of offers coordinated through our People Directorate, as it was at the time, led by our Chief People Officer, in consultation and collaboration with a lot of organisations, including charities, including learning from other major incidents such as the Manchester bombings, using technology. You mentioned a number of apps that are now available to help people with psychological support. I think there are some figures in the statement. We'd need to look them up as to now that I think the number of people who took up some of those offers. So we have, I think, provided the details with you, but I would need to have a look at the appropriate page and paragraph.
Can I ask you this? The inquiry's heard from an expert in general practice.
Yeah.
About the levels of burnout amongst general practitioners in particular, and the kind of support that can be offered to assist in that regard. And Professor Edwards suggested that, like everything else in the NHS, mental health and wellbeing support for staff should be evidence-based, and so there should be evaluations of programmes to see what works and what's most effective and efficient. And that more research, he suggests, is needed to establish what kind of support is effective. And I'd like to know whether NHS England undertook any reviews or evaluations on the support that they provided, and whether you think it would be useful to have more research to know how best to provide support in the event of a future pandemic.
So in principle, we agree that we should evaluate as many programmes as we possibly can that we launch and provide. Again, I can't give you off the top of my head without looking back through the statement or giving you the details separately as to how many of the individual products have been evaluated. Of course, many of the apps that we provided will have been independently evaluated as part of their development. But I would agree that as an academic, I will always agree that more research is better. And I definitely agree that evaluation is an important part of rolling out programmes.
Can we move on then, please, to lessons learned and recommendations? And you've set out in your witness statement, and as we've progressed through your evidence this afternoon, your views on various recommendations in particular specific topics. You've also explained that NHS England undertook an internal lessons learned review which reported on the 20th of June 2023, which I think was a process of pulling together various lessons identified from a range of activities throughout the pandemic, regional and national and local level, as well as some lessons learned exercises, 3 lessons learned exercises conducted in 2020 and 2021. And I'm not going to go through that report, which runs to 150 pages, in any detail, but can we look, please, at paragraph 1803 of your fourth witness statement? Thank you. And we can see there that the report outlined 90 lessons across a number of specific areas, including preparedness and resilience, caring for people with COVID-19, impact on other services. Does that mean essential services, non-COVID services?
Non-COVID services, yes.
Impact on the workforce, vaccinations, inequalities, and managing the incident, as well as the data-driven response, leadership, culture, and innovations. I think it's right that in relation to the recommendations that were made within that report, those are being taken forward currently by NHS.
Correct. We have action plans to take those forward.
And those are largely internal recommendations for NHS England, or are there any recommendations that were made for
They will be largely internal recommendations, but inevitably with these recommendations, some may extend to work with partner organisations.
Were there any recommendations made, for example, to the Department for Health and Social Care?
So this report really focused on the internal workings of NHS England. We have contributed to other exercises in terms of lessons learned. So I contributed, as did Dame Ruth and others, to the Chief Medical Officer's technical report that was published after the pandemic. We have obviously contributed to select committee reports. This is not the only way in which we are thinking about lessons learned and working with other organisations to establish a set of recommendations that we think would be useful. Of course, the inquiry is very much part of that process in our mind, which is why it's important that I and others are here.
I think it's right that some of the recommendations that are made in that report are being embedded effectively into business as usual,
yes.
Changes to services that can be implemented now. But I think it's right to say that some of those recommendations or changes are specific to a pandemic situation. And I think you've identified that there were some changes made to the EPRR structure within NHS England. Regarding that framework, you've said this in your witness statement. There was a difficult balance to strike between enabling local responses to issues as they were seen on the front line and the need to coordinate resources, communication and actions across the whole country. And can I ask you for your views or reflections as to the appropriateness of the timing in how NHS England moved between level 4, which you described to us at the beginning of your evidence, and level 3, the regional level, and whether level 4 should have permitted more flexibility or a greater degree of local discretion, depending on the local levels of pressure or impact?
So I think that's been a thread through pretty much everything that we have discussed today, that balance between the more directive approach and the guidance that is one size fits all versus giving local organisations and healthcare systems the flexibility. We've discussed that in terms of long COVID, we've discussed that in terms of visitor guidance. And it's inevitably a balance and a set of judgments that will change during the course of an incident and will be contextual to the particular issue you're dealing with. So I don't think there's a straightforward answer to that. You can't pre-specify it. I think you need to be aware of it and you need to ensure that you are thinking through whatever policy or whatever process you are involved in, what is at this particular time, in this particular context, the right balance between a more rigid set of instructions versus the flexibility to do things locally. It's not black or white, it's not one or the other, it's a series of judgments. Those judgments won't always be the right judgments. In hindsight, you will inevitably look back and say, we could have balanced it a little bit differently, but you have to make them. and you have to make them in fast-moving circumstances. You don't have the luxury often to wait a week or two. You sometimes have to make them in days, and you have to make them sometimes on the basis of not the evidence being available that you would like to have available. So I think it's right that we think about that, and I said right at the start when I talked about an incident 4 level that although it gave us a command and control structure, it didn't mean that we didn't recognise the need for flexibility and local decision making. And so equally, and I was in this position when I was a medical director of a hospital. You can be frustrated that you are being told to do something, and on occasions you wish you were being told to do something. Both are true.
In relation to the EPRR framework, I think you've noted that the section concerned with inequalities during a major incident has been updated, and there's some specific guidance being developed. Can you assist the inquiry with a little more detail?
So I think the framework is still in development. I think it has been made available, but it's still in development. So I think the sensible thing would be to be in touch with you when we're further down the line in terms of the development of that framework.
One point that you have made in relation to that is that digital exclusion should be seen as another lens within health inequalities. Has digital exclusion been added, for want of a better word, to the inequalities framework?
Yes, and as we've discussed previously, I think digital exclusion or the use of digital technologies both has the potential to exclude, but it also has the potential to include vulnerable groups and those who are disadvantaged. We see that outside of the pandemic in some of the digital services that we provide, where the uptake is greater in individuals who, for whatever reason, don't uptake offers in a more traditional sort of healthcare process.
Data and information sharing. The inquiry has heard from a general practitioner who described a deluge of guidance documents in general practice. Normally would receive 10 to 20 documents in a year, but in the first 2 years of the pandemic received over 400 documents, mostly related to COVID. You've noted in your witness statement that in deciding when and how to issue guidance, NHS England had to take into account the existing guidance and communication being placed on the system, so as not to overwhelm the system and colleagues working within it. Do you think the balance was right? Do you think there should have been more collaboration or cooperation between Royal Colleges and other professional bodies to make sure there wasn't duplication and an information overload?
So again, it's a question of balance. You can give too much guidance, you can give too much little guidance. For everybody who I hear from who says we gave too little guidance, there's probably somebody else who said, I wish we'd had guidance in this area. And to an extent, you will never get that balance right, and nor should you expect to. But the principles, I think, as I've outlined a few times this afternoon, are that wherever possible we want to develop guidance in collaboration with partners. That could be the Royal Colleges, it could be charities, it could be think tanks, it could be a range of people, and of course the public and patients in general. There are limitations about how you can do that in the middle of a pandemic when you are trying to get guidance out quickly, because there is a need to get it out quickly, and that is a trade-off that inevitably you have to make. But the principle is, wherever possible, do that in consultation. And you've given some examples in maternity, how the Royal College of Obstetrics and Gynaecology, the Royal College of Midwives helped us. We can and we do ask other parties, such as the Royal Colleges, to develop guidance on our behalf. So that occurs outside of pandemics, and it certainly happens within the pandemic. So it's not just about us. We can lean into guidance that other people are doing. We can badge guidance that others have produced if we feel that's appropriate and that we can sign up to it. But it's a question of balance and testing the water in terms of whether people feel that they're getting too much or whether they're getting too little, and it will vary from topic to topic. So again, it's one I don't think where you can give a black and white answer. All you can say is you have to be tuned into it, you have to be aware of it, you have to take it into consideration, You will never get it right for everybody, but you try and get it right for as many people and many organisations as possible.
Resilience of the healthcare system for future pandemics. And you've mentioned several times this afternoon the importance of having a resilient system with enough capacity in it. And in your witness statement, you've quoted the former CEO of NHS England, Sir Simon Stevens. He said this: if COVID-19 teaches anything, it is that relying on just-in-time emergency response can end up being more dangerous and far more expensive than building adaptable and resilient capabilities ahead of time. What would you identify, Professor Powys, as the key steps that need to be taken now to build resilient capabilities for a future pandemic?
So I'd answer that in a number of parts. The first is around investment in estate. Clearly, much of the estate in the NHS in England is much older than it needs to be, and that has a whole host of consequences. We haven't talked about it, but I know you will have heard how we had difficulty piping oxygen through to certain ward settings in older estate where the plumbing, the piping simply couldn't take the volumes of oxygen going through it. We talked about the issues of single rooms versus more open wards where infection spreads more easily. We haven't talked, but we could talk about the problems of ventilating spaces adequately. So that means capital investment in hospitals and also in other healthcare settings. You will, I'm sure, have noted that Lord Aradasi published an independent review of the NHS only a few weeks ago, who made exactly the point that there has been an underinvestment comparatively in capital, i.e. in bricks and mortar, in the NHS. So there is no doubt that a sustained capital investment programme to bring NHS estate up to date, to make sure it's fit for purpose across all range of health settings, would give us more resilience. More staff would give us more resilience. I've talked about the long-term workforce plan. That is an area where the previous government and this government, who supported the approach in opposition, obviously they will be looking at the plan themselves, but that plan to expand, double the number of medical school places, increase the number of nurses, increase the number of GPs, simply having more staff and relying less on agency staff, for instance, will make the NHS more resilient. Also having staff that have a more set of generalist skills and are not simply specialists will help, and we are making progress with the colleges on ensuring that will happen. Infrastructure, IT infrastructure, we've talked about data collection, we've talked about the power of data, having better IT systems, having systems that can talk to each other, that can automatically generate the data. And of course, the federated data platform, which we have rolled out after the pandemic, has actually taken the lessons of the pandemic in terms of the data sharing we were able to do. And we are now using that to bring databases together to give us much more insight into population health and into how we can run the health service efficiently. Having said that, and that will give us more resilience, you would still need surge capacity in a pandemic. And it is absolutely the case that even those countries, France, Germany, the United States, that have more doctors than we have per head of the population, who have more modern, up-to-date estate, got to the point where they were struggling to meet demand and running out of capacity, and they needed to put in mutual aid. So resilience will absolutely help us. It will help us in recovery as well. One of the problems in terms of recovering from the pandemic is that lack of resilience. But we will still need to have those surge plans in place. We can't simply rely on more staff, better estate. We will need to do as we did this time and have a surge plan, which is where the importance of planning for the right pandemic and having the EPRR structures around incident responses and having them as strong as possible are the things that will set us in the best possible state for a future pandemic.
Thank you very much, Professor Powys. That's a very comprehensive answer that you've given. I'd like to ask you this. is there anything else in addition to what we've already discussed and the very comprehensive answer that you've just given? Are there any other key recommendations for the healthcare system which you would like the inquiry to bear in mind? Or do you think we've covered all those points this afternoon?
I've mentioned a few. A few I didn't mention would be with respect to NICE, to consider whether they should be a Category 1 responder, which would give them some of the responsibilities and capabilities to stand up. I mean, they stood up magnificently, but I think being a Category 1 responder focuses you to be able to respond in a crisis. I think I have probably mentioned a number of other recommendations that you will have captured along the way. And so I'm very happy to give you in writing anything else that comes to mind other than what's in the statement. But I think you've had a lot of recommendations. And the one thing I would say is going back to long COVID, which I didn't tell you when I answered, is that we do have a registry of long COVID cases, and I will go back and check whether it's in a format that would allow us to say something about healthcare workers. So we will let you know on that one too.
Thank you very much. Professor Paris, I have no more questions for you.
If we could finish you tonight, Professor, I would carry on, but I'm afraid it's just over an hour's worth of questions from the core participants, and you've had a long day so far. So although my ever-efficient ushers have been getting people ready for with lecterns for questions, if everyone will forgive me, I think we'll finish now and come back on Monday, 10:30, the 11th of November, please, and we'll see you again then.
It'd be a pleasure to see you again.
Thank you.
All right.